Okay, then we get the next talk by Rod Escombe. He's will give a talk on more what's happening in the general practitioner environment. And you're yourself a general practitioner from York. Please.
So, thank you, Walter, and thank you, Sue, for inviting me to speak this afternoon. First, I must confess, I'm just a medical doctor, so not as clever as most of you in here. I lived in Peru for many years, where I did my PhD in TB transmission and ways to prevent TB transmission. So first, I'm going to talk a little bit about airborne TB transmission, and particularly TB transmission in healthcare settings, and then looking at natural ventilation in healthcare settings, in low-resource settings in Peru, and then simple interventions to improve natural ventilation. And then I'm going to finish with a little bit of data on ventilation in primary care settings, general practice settings in this country. So we've heard a lot about airborne transmission. I won't dwell on it. Tiny droplets which remain suspended in the air for long periods, produced by all sorts of respiratory manoeuvres, talking, coughing, sneezing, and then all the things that we do to keep patients in hospitals, intubating them, bronchoscopies, induced sputums, COVID tests, all that sort of thing. So hospital environments potentially very dangerous. You don't need to speak Spanish to understand that headline. Hospitales desbordados, overflowing with tuberculosis. And why is that? Well, overcrowding obviously is a big driver of that. Patient flow as well, certainly. You can see some of these very crowded. This is an emergency department. These are various different outpatient departments. Folk have to queue up to see the doctor, then they have to queue up to pay for an x-ray, then they have to queue up to have the x-ray, then they have to queue up to go and see the doctor to get the result, then they may get prescribed something, they have to queue up at the pharmacy to collect their medicine. So they spend an awful lot of time in these healthcare settings, and all the time they may well be exposed to infectious aerosols. Lots of susceptibility of folks in hospitals, folk with HIV, other causes of immunosuppression, elderly folk, folk with cancer. Certainly with TB, there's a massive impact of infectiousness. The most infectious TB patients are those who are untreated, because treatment for TB reduces your infectiousness relatively quickly. Where do you find untreated TB patients? Well, not on the TB ward. You find them in outpatient departments, you find them in waiting rooms, you find them in the x-ray departments, and all these very typically overcrowded areas of hospitals. And then, of course, there's another argument about primary versus secondary care, which I will come back to. So how do we prevent airborne TB transmission in healthcare settings? Traditionally, we have this hierarchy of control measures, administrative control measures, so trying to get rapid diagnosis, rapid treatment of your patient's cough hygiene, covering your cough, and then improving patient flow, trying to reduce the amount of time these folk are exposed. Personal respiratory protection, everyone is now familiar with, and then all these environmental control measures which building engineers and architects like yourself are familiar. A little bit about layout and movement of people. I talked about all this queuing up that goes on in healthcare settings. This example here on the left is very bad. The corridor in the middle is used as a waiting area, and all the folk in the offices and the pharmacy and the consulting rooms are exposed to those aerosols in that poorly ventilated environment. And this was a very simple way to improve that by putting your waiting room outside and having doors opening onto the outside, etc. What about natural ventilation? So Florence Nightingale has cropped up already. This is her in Crimea in the middle of the 19th century. The very first canon of nursing, the first essential to the patient, to keep the air he breathes as pure as the external air without chilling him. Big drivers of natural ventilation, cross-ventilation and stack effect. Nice old pictures here of the old TB sanatoria of the Victorian era, where fresh air was the treatment for TB. This is where I worked in Lima, Santa Rosa. She's the patron saint of Lima. This ward was named after her. This was an old infectious diseases hospital, a fever hospital that was built on the outskirts of Lima, now has been consumed by the city, but this is still HIV, TB downstairs, and Upstairs was respiratory and drug-sensitive TB, non-HIV TB. On the roofs were my guinea pigs, which was another study. And I was working downstairs in some mechanically ventilated negative pressure rooms, which were supposed to have 12 air changes. In fact, they had 1, 2, 3 air changes, as the system had been poorly designed, poorly maintained, poorly implemented, and no one changed the filters, the fans blew out, etc. And I had to renovate all of that with the funding from my study. And I had a look at those wards upstairs, and I thought, I bet the ventilation up there is pretty good. So I thought I'd go and measure it. And this is what I did. So I looked at the wards in Santa Rosa, but also in another 7 different hospitals in Lima. Some of these were old-fashioned hospitals, brought along the design principles of TB sanatoria, fever hospitals, and some were more modern hospitals built in the 70s, 80s, 90s. I looked at all sorts of different rooms where you might find TB patients. TB wards, respiratory wards, waiting rooms, X-ray rooms, bronchoscopy suites, HIV wards, general medical wards, where you might find these folk. How did I measure ventilation? This is an old version of myself, and we use carbon dioxide as a tracer gas. So I got myself some fire extinguishers. You let off some gas with all the doors closed, all the windows closed. You mix it up with some fans, and then you measure the concentration of CO2. And unsurprisingly, with all the windows and doors closed, there's a very slow decay of CO2, depending on how leaky your space is. And then you open the windows, and lo and behold, what happens to that CO2? Well, it disappears. Then you do some maths on that curve to work out your air exchanges. I did over 400 experiments over a couple of years in Lima, over different seasons. And these were the results. So here we are on the left. This is when all the windows and doors were closed. Unsurprisingly, very few air changes. Partially open, that means opening a few of the windows or one of the doors, something like that. Suddenly we're getting some air exchange. The different colours here are the different quartiles of wind speed. White is the lowest wind speed quartile, black is the highest wind speed quartile. And here we've got fully open, so this is all of the windows, all of the doors possible open. And you can see suddenly we're getting massive amounts of air exchange, 20, 30, 40, and the median air exchange was 27 air changes per hour, obviously much greater when the wind was blowing. Big drivers of natural ventilation in this study were, unsurprisingly, window size and then cross-ventilation, having windows or apertures on opposite sides of your building, of your room. So those were the results, and that was very surprising, very impressive. And I've compared it here to the 12 air changes that are supposed to be provided by those mechanical systems. But in my experience of over 30 hospitals in Peru, over 90% of the mechanically ventilated TB isolation negative pressure wards were very poorly implemented and maintained, and delivered 2-3 air changes, if that, or they was just broken and they trying to open the windows instead. Here's a few examples. This is Bravo Chico Hospital, again designed on these old TB sanatoria principles, 20 to 40 air changes depending on the wind. This was upstairs in Santa Rosa, a respiratory medicine ward. This was another hospital, Hipólito Unanue, again a general medical ward. This was a MDR TB ward with some very nice cross ventilation, loads of air exchange. And then I compared these old-fashioned wards with some more modern facilities. So these were built in the 70s and 80s with, according to modern design principles and tighter buildings and better thermal comfort, supposedly. And here we are, we've got some small windows, and unsurprisingly, the ventilation was much less. So I stratified the data for all of those rooms, looking at old hospitals versus new ones. So the dark is the old, and there was a median of 42 air changes in all those old hospitals, compared with, not bad, about 17 odd in those modern hospitals, compared with poor old mechanical ventilation, 12 air changes down here. And then we did some modelling of TB risk of a nurse doing a 6-hour shift in one of these facilities, using background TB prevalence data from each hospital, and worked out the sort of risk of getting TB in one of these settings. And clearly the estimated TB risk is sort of inversely related to the absolute ventilation, which is one of the biggest drivers of TB transmission in healthcare settings. So I went on and looked at particularly some of these waiting areas, because they're just so overcrowded in these low resource settings. And I worked in another 20 different hospitals all around Peru this time, not just in Lima. Some up in the Andes, some down on the coast, some over in the Amazon. And looked at almost 60 waiting rooms, lots of experiments. And again, you close all the windows and doors, you get very few air exchanges. You open them up, you get a fair amount, but it varies depending on the design of your facility. Modelling TB risk, again, with all these different folk and the background TB prevalence data of these hospitals. And there was a decrease, but not as much as you would like. And that is driven by the overcrowding in these settings. So what about research into practice? So this was Hospital 2 de Mayo. This was an outpatients department. So you've got cardiology, gastroenterology, dermatology, all the ologies here in this waiting room, waiting for ages to see the doctor. And what we did, the intervention was to raise this cupola, this peatina, which is a glass kind of roof. It was all sealed. So we raised it up on stilts, and then measured the air exchange before and after. I taped up the aperture I'd made with plastic sheeting, let off my CO2, measured the air exchange, and then ripped away the plastic sheeting and measured the air exchange in the same experiment. And unsurprisingly, here we are, 5, 6, 7 air changes with the old system, 15, 16 odd air changes with the new system. So a very nice little intervention, costs $500 or something to do that. This was one of those consulting rooms which goes onto this waiting room. It had some nice windows going off into the street, and some windows above the door which you couldn't open, so we renovated those so that you could open them. And here we go, prior to the intervention, a few air changes, after the intervention, a whole load of air changes. Another intervention, this was a TB clinic outpatient department next to normal respiratory outpatients, which included lung cancer patients. A lot of these windows, particularly up here, were unopenable. They were just solid glass. So this was my intervention. I went to the hardware store, I bought a hammer, and I got rid of all that glass. And you can see what happened to the air exchanges in that waiting room. This was another example of one of these shared waiting rooms. This was a consulting room for respiratory medicine. We put a new window here to provide cross-ventilation. Suddenly, instead of 2, 3, 4 air changes, you got 10, 12, 15 air changes, depending on the wind, largely. And then the respiratory outpatients waiting area, we actually built a new one and built it outside. So now the TB suspects, the likely infectious patients, are not in here with everybody else, they're out there. And if you're designing things from scratch, you can be a lot cleverer about what you design in terms of making it a good natural ventilation. And I could barely measure the ventilation in this space, sort of 60, 70 air changes per hour. So that was improvements, simple improvements to natural ventilation in a low resource setting. And then we modelled the TB risk in all those spaces. And again, it's not rocket science. Here we are, the blue triangles. These are all the pre-intervention measurements. So the air exchange is much less, and the TB risk is much higher. The red circles is post-intervention. Suddenly the room ventilation is getting much higher, and your calculated TB risk is getting lower. So natural ventilation, well, it's got plenty of advantages, particularly in low resource settings because of its low cost to install, its low energy consumption, and relatively low maintenance. And we've seen from this study, its high rates of ventilation are possible. The other thing to note is that it's applicable to a very wide variety of settings. So I've already told you about where do we find infectious patients. It's in outpatients, it's in waiting rooms, it's in X-ray departments. You can't mechanically ventilate all of those areas. There's just no way in low resource settings to do that. So all you're left with is natural ventilation if climate permits. And of course it's applicable to other situations where you're likely to find TB folks, so homeless shelters, prisons, all that sort of thing. But of course it's climate dependent. Lima is relatively temperate, a bit colder in the winter, 12, 14, 15 degrees. So we didn't open the windows completely during the winter. And you saw when things were partially open, you were still getting reasonable air exchange. But of course it's not perfect by any means. I'm not claiming that. And We don't have any control over the direction of contaminated air, but with a bit of common sense, you can have your MDR TB ward down the end of the garden, in the way that fever hospitals used to be out in the outskirts of hospitals, of cities. Noise pollution, obviously, air pollution, fire safety, security, all problems with natural ventilation, as is privacy, privacy for the medical consultation. So I moved back from Peru, and sadly I now live in North England instead of Latin America. And I now work as a GP in primary care. For those of you who don't know, primary care in the UK is a gateway to hospitals. If you want to get into a hospital, you have to see your general practitioner first. GPs like me, we deliver 300 million appointments per year, and that compares with about 23 million A&E attendances in the UK and about 100 million hospital appointments. So the vast majority of patient contacts in this country is happening in primary care. We've got almost 7,000 GP surgeries around the country, and many of these are in converted residential buildings, old Victorian buildings that have been converted into a GP surgery. So I work in York. This is one of my surgeries, Huntington surgery. This is the waiting room. It's got some of those little upstairs windows. This is a consulting room where I also work. It's got windows here, no other windows, so there's no cross ventilation at all in this consulting room. This is where I spend 12 hours a day consulting 40 patients in a day. The window here, you can only open it about that much. That's probably so I can't jump out of it after 12 hours of all of that. And there's no other ventilation. And so it goes onto a little corridor. The staff room's here. There's an office there. You can imagine the ventilation in that space. This is New Urswick surgery, the old Roundtree, a village that was built by Roundtree, a sweet maker for all his workers in the 20s. Nice old buildings, but pretty small windows. There's a nice big amount of windows here, but only these two leaves open. These are a couple of consulting rooms, got some cross ventilation, but again, only small areas of windows are able to be opened. This is another surgery. Again, you can see good potential for cross ventilation, but just tiny bits of the windows that you can open. This is a waiting room, and this is the only bit of openable window. This door has to be kept closed because just here is reception where folk will come and talk about their medical issues with the receptionist. So it has to be closed, that door. So I came along with my fire extinguishers, and I've been measuring ventilation in those spaces. And I bet you can all guess what sort of rates of air exchange I've been finding in those rooms. So again, closed, very little air exchange, partially open. Well, here we are. Look at the scale on this axis. We're not in the same realms as we were in Peru. This was 3.5 is the biggest air exchange I've managed to measure at the moment. Most of it is between 1 and 2 air changes. And the background rates of part per million at the end of a surgery are, 2,000 odd parts per million of carbon dioxide. So what are we going to do in these situations? Well, we can do things about improving patient flow. Getting your patients not waiting very long, certainly with the move to remote consultations, we're having fewer patients in waiting rooms. However, we're now shifting back towards face-to-face appointments. We now have about 70% face-to-face appointments in my surgery. Cough triage, I used to consult folk and I still do, in the car park if they got a cough and there's a COVID risk. Respiratory protective equipment we all know about. It's very hard to consult a patient, particularly an elderly person, hard of hearing, wearing a mask of some sort. And then improving natural ventilation. Well, in those facilities that I've shown you, it's going to be very difficult, and retrofitting them is going to be expensive. So I'm not sure, and I'm looking to you folk to help me out here. And natural ventilation, you need behavioural change as well. This was in Kailicha in South Africa where I worked. Lovely big windows, lovely big stickers, stop TB, keep the windows open, and of course they're closed. So natural ventilation, sadly, not a panacea. Maybe Clive's Air Cleaners is the way forward. Thank you very much, and go to Peru. It's a wonderful place.
Great, thank you very much for a nice talk. Very interesting.